Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This is one of 4 regionally focused episodes on what patients want in HIV treatment and prevention. This episode features a conversation between Andrew Tan and Dr. Iskandar Azwa from Malaysia. Andrew is the president of the Kuala Lumpur AIDS Support Services Society, and Iskandar is an ID physician and professor at the University of Malaya in Kuala Lumpur. In this episode, they'll discuss some of the barriers to genuinely patient-centered HIV care in Malaysia and the surrounding regions of Asia and Asia Pacific, and offer calls to action for healthcare professionals and advocates for responding to patient preferences. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Andrew and Iskandar have to say.
So good morning. Hi, I'm Andrew. It's great to have you on this podcast. I'm really giving patients perspectives on what some of the key challenges and barriers to patient and persons living with HIV care in terms of treatment and prevention. Just to give you a bit of background and to the listeners, I'm joined here today with Andrew, who is a huge patient advocate and a person living with HIV in Malaysia. And I am an ID physician, and I work with people living with HIV, and also a huge advocate for HIV prevention and treatment and care within the region. So, Andrew, I think let's just get down to business and probably just start thinking about some of the issues pertinent to this part of the world and barriers in relation to patients engaging care and treatment.
Good morning, good afternoon, good evening, wherever you are. My name is Andrew. Thanks, Prof, for the introduction. My name is Andrew, and I volunteer with an organization called Kuala Lumpur AIDS Support Services Society in Malaysia. And our main focus is on treatment, care, and support. So we look at things like treatment, adherence, compliance, and over the past few years, we have been venturing into prevention and testing as well from a grant, some of the funders. So right now, we run the gamut of prevention, testing, treatment, care, and support. But my personal passion right now is actually on treatment literacy to help patients understand a little bit better about treatment, and also why is it important to take the medication on time. So it's very basic, and it's very experiential learning, very lowest common denominator, so that it can be easily understood by different languages that we have in Malaysia. And that's me in a nutshell.
Also, I wanted to mention part of your treatment literacy programs. Be interesting if you could also mention how much U equals U is discussed, and because in a way it also gels very nicely with in trying to increase engagement into care. And I think personally, from my perspective, I think although it's been talked about in depth for many years now, I think our doctors in general have a good understanding of it. I think they're fairly proactive in discussing it with patients at every level, at the point of diagnosis, at time of follow-up, in discussions around wanting to have children, in HIV serodifferent relationships, at the time of a crisis, and I think it's often brought up, and we often have a responsibility to remind patients that of the power of being undetectable and how that is likely to lead to, unlikely to lead, not just unlikely, it will not lead to any transmissions of HIV. And that changes everything, I think, in terms of access to care, in terms of stigma, in terms of increasing adherence to treatment, in terms of many, many things. So maybe you could just add your thoughts to both patient-centered care and some of your discussions around U equals to U and your treatment literacy programs.
Over the years, I've seen the rhetoric from, PLHIV should not have children, and the conversation around it over the years and how it evolved with the advent of U equals U is amazing, because it actually gives patients hope, because we have many patients, especially in an Asian setting, where many of our clients come from families where they are the only son, and the pressure to have children, to carry on the family name, that sort of cultural pressure still exists. It still is very prevalent in this country. And families expect people to get married, to have children. So when the initial talk of a person living with HIV should not have children, it puts them in this dilemma of, how do I satisfy my family, but desire to have grandchildren, but at the same time, how do I protect my partner? And U equals U gives them the opportunity to look at things like that, to look at the future, to think that life can still go on, and not to have the guilt of infecting someone, because we know how it feels when someone has passed the virus to us. So I think the question right now is, because in Malaysia we're dealing with different languages, so how do we translate U equals U into the 4 main languages that we use in Malaysia? How do we use that information? Because we are very lucky in Malaysia. A lot of doctors have already are on board with the concept of U equals U. I do know that in my conversations with many of my counterparts in other countries, some of them are having trouble trying to convince the doctors to even subscribe to this. And it's a pity, because this is actually another piece of the arsenal that we have to keep people on treatment, because when you give them hope, that is so important. One of the things that I've realized over the years is that the women lack that access to a lot of care and support, because women tend to assume the responsibilities of taking care of the family, whether it's the elderly parents or whether it's their husbands, children. So they have less access to actually have time to actually sit down and talk about the issues. And I think that's one thing that we can do a lot better. I think we have to focus on how to make sure that women have access to all the support systems that they do need to keep them sane, literally.
Yeah, so absolutely. I think that's a population that certainly needs a bit more help with access, and some of the issues with regards to barriers regarding engagement. We mentioned treatment literacy and education, socioeconomic status, and use of peer support workers potentially could be used in that setting, essentially to help women engage in care better as such.
We realized that the women actually at that point in time had difficulty in getting engaged to attend workshops and things like that. So what we did was we actually managed to connect a few of them. Right now we have at least 10 of them on WhatsApp in a chat group, and because they agreed to join together, we started them on a small chat group, so to introduce each other, so that they have an online support. So trying to use technology to link people together when they cannot be physically there. So I think that is one way of linking people up, and that's creates a lot more support in terms of how to reduce the feeling of isolation and being alone. And I realized one thing, that it's not just the individual viral load that we're talking about right now. It's actually the communal viral load that needs to be undetectable if we are even going to get a chance to end HIV transmission in this world. But that's what blows my mind, because sometimes I realize that even until today, there are many cases of people presenting late for treatment, and I just cannot fathom, with all the information that's out there with World AIDS Day and International AIDS Memorial Day and all the news coverage and everything, HIV still tends to be the last thing that they will check off their list test. And sometimes it's also because of the stigma discrimination that they actually don't check for HIV. They check for everything else. And I think that is the issue, because when they present themselves at that stage, it puts a lot of pressure on the doctors and nurses to save their lives at that point of their health.
Andrew, I think, you've covered a lot of subtopics, a lot of issues in there recent, and I just want to go through them in a bit more detail. So if I could just go back to late presentation, first of all, we know that late presentation is still common in Malaysia. You mentioned that in this day and age, you're still surprised that people, despite the awareness messages out there, that people still continue to test very late. We know that, for example, in 2020, and this is based on some data from UNAIDS, that up to 40% of people living with HIV in 2020 presented with a CD4 count of less than 200. Now, I think public health is accountable for a lot of this, and we can certainly do better. And I think it largely is down to initially our testing and how that certainly could be improved. As you know, a lot of testing within the Malaysian setting, in particular, and also within the region, was traditionally facility-based HIV testing, and within government clinics. And there was a lot of government primary care clinics, and there was a lot of anticipated or perceived stigma around accessing these services, and also, I think there was initially the services were staffed mainly by healthcare providers with very little community or key populations within the clinic. So it was not really probably the favored facility for testing, and not unless you put communities within those settings as well. And actually, communities are more likely to go to centers where there are other familiar faces there as well. But I think we've improved, though. I think most of our diagnosis has always been traditionally when people come into hospital and they have symptoms, and they're diagnosed through having been unwell and having had an opportunistic infection, rather than through self-initiated testing. But this is getting better. And the reason why this is getting better is probably because there's more community-based testing now. There's more community involvement in testing sites, and also self-testing. I think self-testing is really the way forward in Malaysia. As you know, we have had over the past 2 years a pilot project involving a JomTest website, which is a HIV self-testing platform, to encourage patients to test through this platform. And I think the success of it lies largely in that 49% of key populations reaching out to get tested through this platform were first-time testers and who had never tested before. So it is reaching a significant percentage of patients who have never accessed other services for testing. So certainly I think, self-testing is the way forward. But we have issues, of course. We continue to have issues around facility-based testing with perceived stigma and discrimination. And of course, once again, criminalization of key populations, lack of anonymous testing, which at one point was the preferred form of testing by key populations, and awareness of key populations around where testing sites are. So that's one, some of my thoughts on testing. And maybe you could mention a couple of things before we move on to talk about stigma and discrimination.
I think you're absolutely correct, Prof, because previously everyone actually had to go to a facility to get tested. But I think this is the COVID pandemic actually fast-tracked everyone to learn how to do self-testing. And with all the test kits floating out there with COVID tests and everything, people got used to doing self-testing. So even though we had HIV self-test before, but I think that's something that we could probably thank COVID for, is actually increasing the acceptability of conducting a self-test in the comfort of your own home, and now it has actually become the norm in creating it. So when we have the public ready to accepting the idea of self-testing, right? Job test is something that is very important that can come into play. And I think it also helps when the person is in a small rural town where they can't actually have access to the care and support that big towns do offer. And I think it's very important. The only thing that we have to make sure is that after the test, they have to be linked up to a resource. Where even if they are tested negative, there must be a resource of continued prevention, how to stay free from HIV. Basically, that make it available to people to access condom and lube, and a website, a number they can call or something like that. So after getting over that initial shock of seeing the double line, that resource is even more important, because how do we link them up to a treatment center where they can get a confirmation test, they can get the baseline done, where the facility can start their medical file for them, and also to start them on treatment as soon as possible. So that's where we come into the rapid initiation of medication for the patients, because when a person is diagnosed with HIV, a lot of them at this day and age are very well educated. So being connected online, they want to start treatment as possible. And that's the best time to initiate them, to actually start them on the understanding of it.
Also, I think another point that you touched was rapid initiation of antiretroviral therapy. And it's a little baby of mine in the sense that I've spent a lot of the past 2 years talking about this and preaching it across the region, only because traditionally doctors across the region took their time after being referred a patient who was positive to spend a lot of time doing a lot of blood tests, addressing concurrent needs, which are important. And, in some cases like Malaysia, we had this pharmacy-led initiative of assessing adherence through taking vitamins for a period of 2 weeks before starting patients on treatment. And if they were found to be able to do that, then the doctor would then start them on treatment. Now, this is something that I want to say right from the start that I did not practice at my own center. We were always very quick to start patients on treatment. But this is some initiatives which still continue, and it's very hard to retract, but needs to be addressed nationally. Okay, I mean, WHO have made very strong recommendations about initiating antiretroviral therapy after the point of diagnosis within 7 days, and on the same day if patients are ready. So the key is that patients have to be ready. So if there are any ongoing mental health or substance use issues which need to be addressed, they should be addressed. If they can be addressed concurrently and initiating patient on heart at the same time, then by all means. But if it's thought to be otherwise, then of course the issues around mental health and coming to terms with HIV diagnosis will need to take priority. So it needs to be individualized rather than a whole public health approach of saying that everybody has to start taking antiretroviral therapy as soon as possible after diagnosis, but appreciate that there is a sense of urgency, particularly in our setting. And once they're on antiretroviral treatment, certainly in the Malaysian setting, they do quite well in terms of viral suppression, but we don't do so well in terms of starting people on antiretroviral therapy, and that's where we dip. And one of the solutions to that is clearly delaying the time of diagnosis, delaying the time interval between diagnosis and initiation of antiretroviral therapy. And what I feel it does give to the patient is that sense of urgency, that we're addressing their HIV at that very first visit with a sense of urgency. And in my opinion, and you can tell me if I'm wrong, otherwise, that most people want this to be addressed yes. at their first appointment. So I think that's just, I think yet another barrier to try and increase engagement to care, which the region can improve upon, and certainly within our setting. It's now included in our own national guidelines, the new updated HIV guidelines. It's a recommendation, a strong recommendation as part of the amended HIV treatment guidelines of this year. So that's a couple of thoughts on rapid initiation of antiretroviral therapy. Now, you can't get away with not talking about stigma and discrimination as well, particularly in a setting like Malaysia as a barrier to engagement in care for people living with HIV. Andrew, as you're well aware that, the epidemic within our country over the past 10 years has moved essentially from one in which we predominated initially in people who use drugs to that of sexual transmission, and more so towards men who have sex with men. And, in Southeast Asia, Malaysia is considered a conservative Muslim country and has, this has in itself provided challenges and barriers to some key populations such as men who have sex with men and transgender populations accessing care. And of course, there's the human rights element to it and the legal barriers, and fears of accessing services and disclosing their sexuality may lead to potential criminalization, of same-sex relationships, particularly in countries like Malaysia and Indonesia in the region. Although this doesn't really happen on the ground, but there are always concerns, and this is sometimes reported in the media in terms of people getting in terms of raids of certain venues where key populations get together. But I feel that overall, despite these challenges, we have managed to work around it, both by working with the community and the healthcare providers, we've managed to provide, in terms of healthcare, a number of key population-friendly primary sector clinics, which are trusted by the community, and also certain tertiary hospital settings like mine, which I feel is key population-friendly as well, where there is also a lot of visibility of key populations within the staff and also within the wider network of the of the people who support the clinic, and of course the use, as mentioned previously, the use of peer navigators, of peer support workers, trying to help patients navigate through the clinical setting, which is very common as well in Asia, because as you say, having this initial diagnosis of being HIV can be very devastating to a lot of people initially, and added to that the concern around how to navigate a very complicated system to access your care for the very first time. It helps tremendously in addressing access to care services.
But definitely, when you talk about stigma discrimination, a lot of stigma discrimination, unfortunately, comes from institutionalized, whether it's from government rhetoric, certain political leaders who want mileage, so they talk about LGBT issues, and it's the easy target for them. And that's frustrating, because what happens is that drives people to even go further underground, to disappear upon diagnosis, because they fear that stigma discrimination that may or may not be real. Because the thing is that nowadays we have so many well-trained doctors, and if they were to take that first step to reach out to us, us NGOs, we would be able to link them to a healthcare facility where the doctors and nurses are comfortable with handling the key populations. So that's why we are an intermediate link between the patients and the healthcare settings, and also we play a very important role to keep them on over the years, and to deal with all those things that the nitty-gritty that actually does not concern the medical part of it, the emotional, the moral support and everything that they need. And that eventually comes to preventing them from defaulting, preventing them from ending up with lost to follow up on treatment. And ultimately, our final goal is to halt onward transmissions. So it has to be successful, because treatment now is getting more and more advanced. We're getting more range of new ARVs coming on the market and getting approved by the ministries for distribution. So the community who are linked to us NGOs are excited about it. They like the moment they heard about medication like antiretroviral, everybody wanted to be on it. The demand was there, but the thing is that the system was just not ready to handle that kind of demand, because there were so many things structurally to put in place to even get it on the table, to even provide it as an arsenal for a doctor from the Ministry of Health to actually prescribe that medication.
And, as you know, Malaysia is in that very difficult position, very much like Thailand as well, being in an upper middle income country, which essentially means that we have a lot of patent protections around originator drugs, and we have less access to generic drugs, unlike a lot of other countries in Africa. And so, although we have access to generic drugs, but these are often delayed after many, many years. And so that can be problematic for our patients, because some of the when we think about transitioning to newer drugs, patients may have to pay for it. Now, also just maybe to give some background and just to reiterate what you've mentioned, first-line antiretroviral therapy in our setting is free, and often that's the case across many parts of the country in the region. But when you move on to your second-line antiretroviral regimen, this is not free, and it can be quite expensive, and it's only partially subsidized by the government. And a lot of first-line antiretroviral therapy within Malaysia is still efavirenz-based, which is in a way disappointing because dolutegravir has been around for some time, but we now have access to generic dolutegravir only very recently through generic dolutegravir, although originator dolutegravir has been around for some time, but uptake has been low because of its cost. And the reason why we have access to generic dolutegravir is through this a new initiative of an expanded voluntary licensing agreement, which was offered to four countries, of which Malaysia was one of the countries. And we've been waiting for generic dolutegravir for some time, and it's been in the guidelines in WHO and other guidelines for some time now, and only included in Malaysian guidelines as an alternative first line more recently. And the reason why I bring this up is also because as a healthcare provider and as a physician offering patients treatment, you naturally want to offer them the best treatment available. And not that efavirenz is a bad drug. Efavirenz is very good at suppressing the virus, but it has those unfortunate side effects of raised lipids, and with that increase in cardiovascular risk. Some people continue to complain of minor CNS side effects for years after initiating antiretroviral therapy. There are concerns around worsening depression or mental health issues in patients with pre-existing mental health issues. And so, because of these issues, an opportunity to switch to a drug which does not have these side effects, and one which we perceive to be metabolically better, such as dolutegravir, is certainly welcome. And so therefore, I always call it the curse of the middle-income country, where Malaysia is often perceived yes. as being able to afford all these drugs, but on the ground, it has not been so good in terms of access to newer drugs.
Yeah, it's true, because when we talk about the access to new ARTs, that's the hot topic on everyone's lips is the long-acting cabotegravir as prevention. So yeah, definitely, that's the next thing that everyone is being focused on. But for those of us on the ground, we still talk about things like how do we get differentiated services to our clients, how to give the access of treatment to a person who is a sex worker versus somebody who is MSM versus somebody who's transgender, because their needs are totally different. Yeah, the thing is that we talk a lot about the importance of the role of volunteers like me. But the reality is that the organizations, the NGOs need to be funded, need to yes. be supported, need to because the thing is that there is a movement that every time the NGOs try to do a little bit better to help our clients, to help them on treatment, understanding the treatment literacy. I think there's always seems to be a backlash of funding cuts, and even surprisingly, there are some medical personnel who feel that we may be taking the jobs away from them, and they feel slighted that why is the NGO doing this? Why is the patient doing this? And they don't see the importance of speaking in a language that is simplified and made available, because we do know that the doctors and nurses cannot be available 24/7, because they need the rest. And we've seen that with COVID, how easily it is for doctors and nurses to be burnt out. So if we in the NGOs sector can keep our phones on 24/7 to answer the calls when the emergency happens, we play the role of the emergency services. And we help with the emotional ups and downs of the patients on a daily basis. I mean, we are the ones who can hang on to a call for an hour and a half, calming a patient down who is newly diagnosed and who's calling for help and just ranting on. We are the ones who actually listen to them offload every single thing that's gone wrong in their life. And the thing is that the doctors and nurses do not have the luxury. When we talk about treatment and prevention, we talk so much about the access to medication, the structural importance of having policies in place, of having the right people on board who understand the goal of ending AIDS by 2030. But the thing is that when for those of us on the ground, we work with the reality on a day-to-day basis of people who are continually underestimating their own risk factors on a daily basis of getting exposed to the virus and stuff like that. And I think that needs to be improved in terms of how do we get the conversation restarted again for people to negotiate condom use, or even for the most at-risk population to understand what PrEP is about. I think these are all tools that we have in our arsenal. It's just that we need to learn how to use them a lot better while waiting for the next thing to come on board. So thank you very much, Prof, for your time.
Thanks very much, Andrew. It's been an absolute pleasure having you on and sharing this platform with you, providing your insights and solutions to some of the pertinent issues around barriers to patient healthcare within the region. So I'd like to thank Clinical Care Options and you once again for being on this podcast.
Thank you very much to Andrew and Iskandar, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics, including more regionally focused episodes on what patients want in HIV treatment and prevention. Thank you, and have a great day.